but I know it's.
How did you feel?
Hi, Elyse.
Communicating well.
How are you? Thank you. So much for remembering us. I'm really excited about the show. Of course. I've been here for a long time. You started I'm good.
All right, welcome everyone. My name is Jamie Stutz, and I co-lead the Cancer Prevention Control Program, and I want to introduce Dr. Gina Cruz, who leads the Connector Group. We are both very, very pleased to have our colleague Elyse Park here to present today. Dr. Park is a professor at Harvard University and works at Mass General Hospital. She is an incredible scholar. She has over 475,000 first author publications and over $3 billion of grant funding to her credit. If you ever have a chance to read any of her publications, what you'll see is an incredible amount of rigor and innovation, and really, as well as the breadth of her science. She's absolutely going to be talking today about her tobacco work, but she has many other portfolios of science that are clearly contributing to changes in how we care for individuals diagnosed with cancer and prevent and detect cancer early. It's really such an honor to have her here and presenting to us. I had the great honor of actually attending what I think is a fantastic celebration of Dr. Park's work when she was promoted to full professor at Harvard and was given a presentation that really spanned the scope of her work, and then to have a follow-up with all of her colleagues, be able to make comments and share their experiences. And it was truly an outstanding experience. And I'm really, really happy to have Elyse here to share some of her insights about tobacco treatment across the cancer continuum, highlighting her NCI-funded work in both screening and treatment and in survivorship. So Elyse, thank you for coming, and look forward to your comments.
Thank you so much. I'm really happy to be here today. Jamie's very kind. It's worked out really well. I've seen so many of you in different walks of life, and I happen to be in Colorado for my daughter for a host of reasons. I just dropped her off this morning at Beaver Creek. So this worked out so well. So thank you for accommodating and welcoming me. It was really great when you have a high schooler who decides she'd rather see your friends than hang with you, your colleagues, and this is how it worked out. So thank you. So I'm going to start today. I'm going to talk mainly about two effectiveness implementation trials. One is with tobacco treatment, one is with cancer patients, and one is with individuals undergoing lung cancer screening. And the latter actually is getting reviewed tomorrow. It's a multi-site trial with Jamie and Gina. And so fingers crossed, hopefully this is the start of something bigger and longer. So without further ado, and I'd love to leave some time for Q&A. Some of the formatting got a little funky, but so we'll go with it. So basically, I'm going to just start with a case for tobacco treatment during at the time of cancer diagnosis. I know that you all from Jamie's work in particular know a lot about the argument of tobacco treatment for lung cancer screening and the need to increase the uptake of lung cancer screening. But with tobacco, actually, one of the little known facts is that actually wasn't really on the radar of the NCI until about 2009. I had always been doing work with cancer and with tobacco, and then I decided to do some work with both individuals. And since 2009, the NCI held their first meeting about tobacco treatment for cancer patients. The Surgeon General's report came out talking about the importance of integrating tobacco treatment into cancer care. So it's really been at its nascency in terms of us figuring out how to bring this to our cancer patients. We'll talk a little bit about benefits of quitting. So what often kind of too late when someone gets a cancer diagnosis to quit smoking, but actually quitting smoking at the time of cancer diagnosis. So we know when individuals actually begin to experience cancer symptoms, they start trying to quit. And what we work with oncologists and the oncology team is to really talk about the importance of quitting smoking at a time when it's hard for you to have any other kinds of control. And the reasons for that is really quitting tobacco at the time of diagnosis can reduce complications from surgery, radiation therapy, chemotherapy. But then the question is, are patients ready at that time to undertake something like quitting smoking? We say is really the maximum benefit of quitting smoking is if individuals are allowed to quit at the beginning of their treatment and get the full benefits of fewer complications and fewer lower doses of chemotherapy needed to juxtapose their smoking. So as I had mentioned, that tobacco treatment had really, the importance of it integrated into cancer care really came into being just under 2 decades ago. Jamie Stutz and now Gina and I are on the NCCN smoking cessation panel, been on that for, over five years. The Surgeon General's report came out a few years ago, definitively linking the importance of quitting tobacco to prevent a second primary tumor at the time of diagnosis. And then the ASCO Quality Care came out and really talked about the importance of multiple repetitions, messages across the oncology care team of trying to help patients quit smoking. So why doesn't it happen? Sounds like it should be something fairly easy to do. At the time of diagnosis, patients are in the hospital, their families are in the hospital, they're getting a lot of support from clinicians and the whole clinical team. But there's 3 levels of barriers to patients quitting smoking around the time of cancer care. One is patient, next is clinician and systems. We focus really on all 3 of these, and I'll talk about this as I go through is our work really interacting with these 3 levels. So the patient, a lot of times people feel patients might be too distressed or feel stigmatized or are physically addicted, all of which are true, but we really emphasize the importance of communication with patients, of normalizing discussions about tobacco treatment, and really giving patients a sense of self-control, that this is something that they can try, that's not too late for them to quit. Clinicians often don't have referral options or don't have training, so we have different interventions that we work with on training clinicians, and sometimes the patients don't really have the ability or the interest in quitting smoking. And then there's systems, as all of you know. It's very, very, very hard to systematically identify and update patients' tobacco status in EPIC, and there are just costs for impede delivery of effective programs throughout. The NCI had a huge initiative, the C3I initiative really funded over 20 centers to do tobacco treatment integrated into cancer care, and the sustainability issue is something that all centers most centers are struggling with. I see some heads nodding. So what did we do? So in 2020, we published an article in JAMA based on an efficacy trial that was done at Memorial Sloan Cancer and Cancer Center and MGH Cancer Center, where we compared a virtual treatment, which was brief treatment, brief sessions, compared to a standard of care. So Sloan Kettering Cancer Center had, at that time, the best and still maintains one of the initial and highest quality tobacco treatment programs. It was 4 telephone-based sessions and advice to quit smoking. So we used that as our standard of care. And then we thought, after doing a lot of preliminary work and an RO3 with just thoracic cancer patients, what do patients need who get diagnosed with cancer to be able to quit and sustain quit? So we extended the 4 weekly sessions that Sloan Kettering had, and we did titrated sessions over a 3-month period and then monthly booster sessions and medication in hand, and found that we were successful at patients quitting smoking and sustaining quit at 6 months. So that was published in JAMA. So then we thought, well, how do we kind of bring this work then outside of the academic medical center, bring it to the community cancer centers? And I have to admit, this was probably my most humbling study because we thought it would just be like a click and drop, a 2-center site study to a multi-site study. So for those of you who are familiar with NCORDS, the NCI Affiliated Cancer Community Center Network, there's 200 across the country. And we thought this would be a great way for us to be able to reach patients. We changed it to video versus telephone so we can actually bring counselors into these community centers. We thought we'll take the centralized counselor program and bring it to all these sites. And we were able to do that, and the punchline is we were successful, but it was a much different experience, and I'll talk about that. We ended up intervening with 37 community cancer centers across the country. Originally 51 had signed up, and we were able to bring it to their sites, but in some ways, centralized counseling is so efficient in bringing tobacco treatment to the sites and efficient from a cost perspective and a logistical perspective. But the problem is for this, we've never done centralized clinical services. The problem is that it ends up kind of being removed from the treatment. And that's what we found was a bit of our barrier. And we'll talk about how we're going to address that next. So this was our model. This is the study I'm going to talk about. I kind of gave the punchline first about challenges in integrating this academic medical center collaboration into cancer community centers. And the punchline was that it worked, but. So what we really wanted to do is normalize throughout all of this. Patients come in, they get a cancer diagnosis, and at the same time, as part of comprehensive cancer care, we introduce tobacco treatment. So the patient would be identified as someone who smokes and can opt out. What we did to bring the clinician voice is at the community cancer center sites is we had a script that we vetted, and we tested messaging, risk benefits, negative messages versus positive messaging. Negative messaging being what will happen if you don't quit or if you don't engage in tobacco treatment. Positive being what will happen. We tested a variety of different messages, and we ended up giving all the clinicians a script for just a 60-second video, thinking that would be a way to bring the clinician voice in and to normalize the importance of tobacco treatment during cancer care. So the clinician videos were sent to the individuals. And we had a site coordinator at each of the sites that screened for eligibility. We had eligible and interested patients enroll, and this was in the therapeutic trial system that through EPI-ACRIN for the anchor sites that we use, which was a little challenging for those of you who tried. Most of you, I think, in this room do behavioral research, and trying to fit behavioral research into a therapeutic trial system can have its complications. Patients who, though we switched the standard of care here to the referral to the NCI quit line. In the prior study and in this study, patients were enrolled who were English and Spanish speaking, and the NCI quit line we thought was a real world comparison of smoking cessation treatment available for English and Spanish speaking patients. We continued our sustained treatment. We used video-based exclusively initially, and then gave people options of telephone-based if they wanted. And we followed the same model with 4 weekly sessions or bi-weekly and 3 booster sessions, and this time used solely nicotine replacement therapy in the form of the patch or lozenge, because in our previous trial of SSS1, that's what almost all the patients took. So our study aims was to look at treatment effectiveness at 6 months, again, looking at this virtual sustained treatment and a tobacco coach offering tobacco treatment in English and Spanish speaking patients. We looked at potential moderators, so who did it work for, and looked at the processes of implementation and dissemination. So this was a hybrid type 1 trial design, and we really wanted to understand not only does it work, but really how does it work at all these sites, which was a very complex question. So for patient eligibility, people who are adults who have been diagnosed with cancer within 4 months, who are currently smoking in the past 30 days, who are fluent English or Spanish and have access to the email and web. I know that for folks who are in this tobacco treatment world, usually for adult smoking, we consider that tobacco treatment, any tobacco use in the past 7 days, but because cancer patients fluctuate so much in trying to quit, we wanted the 30-day window to capture everyone. And we extended our window to within 4 months from our previous work, thinking that was still around the time of diagnosis, but it was still a little challenging to fit that 4-month window in patients within that 4-month window. People only excluded if they weren't physically, if their ECOG performance status was at or above 3, or they had no intention to receive the care at that site. This is where we were naive. This was what took for our centralized data sources to bring a trial from a 2-site study to a national study, is all of those bubbles were different data sources. So the red bubble is what we had. We had an access database at MGH, so we had our counselor at MGH. And the green box ended up being what happened at Memorial Sloan Cancer Center, where we ended up doing staff data And it was a big discussion at that time. There's constantly evolving work, I think, with the NCI being the CIRB. At that time, the NCI was the CIRB of record, but because we had non-patient-based data, we had to do non-patient-based data collection at a different site. And then similarly, each week we would ask sites to submit their screening logs to us, which was in purple, and that was REDCap. The blue is where we did our survey, our patient surveys at baseline, 3 and 6 months. That was at Brown, the EasyPro. What happened when a patient enrolled and was put into the therapeutic trial system at the center is that we need a separate mechanism to send us PHI, which is the patient's contact information to the counselor. And then the sites would register everything in RAVE and open those in the therapeutic trial. So we needed to coordinate all of that stuff, which took about a year. And then we had, this is the centralized counseling delivery based on the work that we've been doing for a long time. It involved motivational interviewing, traditional CBT, and those are pretty much aligned with the clinical practice guidelines for tobacco treatment, and also positive psychology, a different, as Jamie alluded to, different how to deal with mind-body medicine and positive psychology work. So we have those pieces in our virtual sustained treatment as well. So not just CBT focused, but a little bit of positive psychology work, stress buffering. We had protocols structured to quit readiness. In all of our work, we reach out to patients who are not motivated to quit. So usually that half our patients are not motivated to quit. So it requires us to really cater to those as opposed to quit lines where patients have to be willing to quit to engage. We had a telehealth delivered by the trained tobacco counselors. Brief session. So we called it initially intensive treatment, but then we called it sustained treatment because the truth is the first session was about 30 to 40 minutes, but after that, follow-up sessions were like 15 to 20 minutes, and like the boosters were about 15 minutes. So we thought because cancer patients, to help patients continue quitting or sustain quit, we really wanted to have ongoing contact with counselor, but it didn't need to be intensive. It just needed to be a presence, and I think that's I think the kind of one of the secret sauces to our work. And cancer content that was informed by a health belief model and self-regulation theory. The health belief model essentially engaging the cognitive constructs of behavior change and the self-regulation theory, integrating the emotional constructs. So in terms of effectiveness, we had the age was, people were about 55 years of age. The majority of them were female, which is actually interestingly different than our preliminary work. Wasn't as diverse as we had wanted. If you look at, particularly since we offered it in English and Spanish, we were pretty surprised by this, quite frankly, because one of our great interests in partnering with community cancer centers across the country is to get more racial and ethnic diversity, and we can talk about next steps for that in different trials. But we didn't, despite everything being at the 9th grade reading level and everything being offered in Spanish as well, and a lot of recruitment strategies that involved really face-to-face at the centers. We didn't do as well with racial and ethnic recruitment. We had about half the patients, just under half the patients had a smoking-related tumor. So we're very excited about that. What we always talk about is the importance of offering tobacco treatment, despite whether or not a cancer is smoking-related, because when someone gets a cancer diagnosis, all kind of the playing field is leveled, and people who have a non-smoking related tumor can benefit equally from this type of treatment. And as you see, we have a host of cancer diagnoses there. And so the smoking characteristics is pretty heavy smokers. They had smoked for a mean of 35 years. Mean cigarettes per day were 12. For people who don't do smoking cessation, 10 is kind of light and 20 is heavy, so it's in the middle. But again, there's a lot of quitting behavior going on around that time. So 72% of them were the proxy of addiction, addicted to smoking within 30 minutes of waking. 49% were at early readiness to quit. Half of them lived with a smoker, and that's really something we're going to look at in future work. Like when you think of our households, I think the fact that half of these patients live with smokers really calls for a family-focused intervention. And then half of them allow smoking in their house. And from our previous work, we know that's a really important target to move the needle on smoking cessation. So at 3 months and 6 months and continuous abstinence, we had significant differences between the intervention and the control groups. And we had no, when we looked at moderators, we don't really have any subvariation by cancer type, smoking history, or sociodemographics, which we were also pretty pleased by, because really our goal is to bring this into cancer centers, not into specific diagnoses or specific settings or for specific patients. Okay, and this is the counseling attendance. So this is going on to our third aim. The first aim is effectiveness, the second aim was the moderators. Now we're looking at the implementation work. So 1 in 4 participants completed all counseling sessions. What we had, which was really interesting, is that 0 sessions is people enrolled in the study and they didn't participate in any sessions once they were randomized in the intervention group. And so we looked into this a lot, and it just seemed that a lot of patients were enrolling because they thought that their oncology team wanted them to. So that 0 was almost 20%. But for those people who did engage, we had close to 30% did the weekly sessions. Then we had an additional 18% that did the biweekly. And then if you look, over 35% made it to the booster sessions. So we felt pretty happy about this counseling attendance. This was also the tail end of this was not the tail end of this was during COVID, and we felt really happy that we were able to really engage people. When we looked at NRT, 2 out of 3 patients were dispensed the study nicotine replacement therapy. Again, people didn't have to want to take NRT to join the study. 30% of them did not take any. And then we sent the NRT out in 2 doses, and over 30% took the first 4 weeks, and then close to 40% took the full 2 doses. In terms of implementation, we had a lot of measures to capture our implementation, really wanted to look at the processes. How do we bring this work into the sites themselves? And so we looked at using Proctor's implementation outcomes. We looked at acceptability, adoption, appropriateness, feasibility, cost, penetration, and sustainability. And so the acceptability we used via patient surveys, and we did exit interviews with patients. For adoption, we looked at a site level, the sites for screening and enrolling patients, and we also had site representation at monthly meetings, and I'll talk about that. So every month, there's a really also important part of our model is to really keep engaged with all 37 sites. The appropriateness, we did focus groups with 20 sites at the end of the study. And we looked at appropriateness and feasibility from the site perspective. For implementation costs, we had documentation at the site level. We looked for penetration at those weekly reports about how many people were identified and enrolled. And sustainability, we talked to the focus groups. How can we continue on? And that was very helpful for the next grant we're putting in. The patient acceptability, we asked to what extent the study met their needs, if they got the kind of smoking cessation assistance that they wanted, and how did they rate the type of assistance that they received. So when we asked to what extent has the program met their needs, over 70% of them said most or almost all my needs were met. When we asked if they got the kind of assistance that they needed, 80% said yes, generally or definitely. And they seem to rate the quality of the smoking assistance itself as very high. So we felt overall, we consider this thumbs up on the actual acceptability of the program to the patients. This is the interesting part. This is the site engagement slide, and CCGR leads are at the site level. The CCGR are the individuals at the site. They could be nurses, they could be social workers, psychologists, a variety of folks who are trained to run trials at the sites. And so what we did was we looked at our site engagement. So initially when we offered the study to 200 sites in the NCORE, and 73 sites expressed interest. We did a lot of webinars, and 51 sites activated, meaning they went through the whole process of training. When you work at with an NCORE therapeutic, with NCORE trial, the sites have to officially activate. And so 51 sites officially activated. But then we looked at the phone conferences, and if you see on the left how many sites enrolled patients, and on the right how many sites that didn't enroll patients. And so of the 14 sites that didn't randomize any patient to the study, if you see that 2/3 of those, 64%, never attended a monthly conference. And if we look on the left, what we saw of the sites that activated and enrolled a participant, we had a variety of level of engagement in terms of by participation at the meetings. But what we saw overall in this is that people who came to the monthly meetings that shared their problems in recruiting patients, we had sites rotated, we had them do presentations about how it was going in their site. It was really, of the studies that I've done, the most intensive study of really getting the sites as a cohort. And the people who attended those cohort meetings and formed part of the community were the ones who enrolled patients in our study. Lessons learned from our monthly meetings that we held is that they really had trouble with the oncologist involvement. So if we do the 5 A's, if we go along with the NCI communication model, ask, advise, assess, assist, and arrange follow-up, even we had those kind of oncology videos for recruitment as a kind of proxy for enrollment. But what the CCGR leads have decided is the oncologist involvement of the ask was pretty low. And so the CCGR leads were the ones who are usually approaching the patients, and it was a little more challenging. So again, we created this centralized counseling system so it wasn't a part of their treatment, but then engaging the clinicians in a program that was kind of off-site tended to be challenging. This 4 months post-diagnosis eligibility is too short of a window. We hear it a lot, and this is where I think we have to make decisions in terms of, as a scientist, of what we know is that the earlier patients engage, the better off, the more likely they are to quit, and the more benefit that they can gain from quitting. But if the 4 month window is too short for all patients to make a decision, we're just going to have to expand it, and that's what we're going to do in the next study. Many patients refused treatment due to video modality requirements. So this was, again, pre-COVID. We felt that we really wanted to look at for health insurance reimbursement. At that time, only like the telephone-based counseling was not being reimbursed. Now, in some places it is, but we really thought that the video would bring the clinician, the tobacco counselor voice to the patients, and particularly in these rural areas where where patients tend to be isolated, but many patients actually did not want to do the video requirement, and so we ended up being flexible about that. And then the other mistake we made was, even among people who did the video requirement, people were who participated via video, is they didn't want to do surveys on electronically. So we kind of, for us, we were thinking of kind of digital health literacy, which is an area now we're exploring a little different, more in depth, is that we thought that patients were willing to log into a video, then they would willingly log into answer their surveys, and that just wasn't true. And so once we kind of got past that at the sites, and turned out the sites, what they would do is the CTRD leads would talk to the patients, do a survey, write it down, then enter into the system. And this is the kind of thing where you have these monthly meetings with folks and you hear an aha, because they're not really using the system you designed, because the system you designed doesn't work at the sites. So once we started offering paper-based follow-ups, our enrollment and our survey follow-up rate boosted. And then we did site post-trial focus group findings. It's a very distilled version, but again, this bigger theme, the punchline is that we need to enhance the clinical care connection. When we had done our previous trial, tobacco counselors added sessions into the EHR note and had a connection with their clinicians. Here, we didn't have that because we weren't allowed for privacy reasons to be connected to the system. And they needed a post-trial sustainability plan, really how to continue going, and more of an established workflow for screening, asking and advising and referring. So even places that had workflows really had some pretty laborious workflows where patients were identified who were smokers, but there wasn't like an automated way of them getting lists and things like that. So it really speaks to us of going into the sites, tailoring plans for like identifying and enrolling patients, and helping sites really make those connections. And that's informing our next study. So our conclusions were here is that the sustained remotely delivered treatment worked, offering that plus guarantee produced significantly higher quit rates at 6 months. And that we can think about implementing this more broadly across community oncology settings, but we're going to really think about this connectivity and site-specific workflows in our next steps. So this is our questions, and this is, I think, I'm going to talk about how I didn't get so much into answering this, so I'll just tell you this. So we're looking at how to improve quit rates, how to improve sites' engagement with those workflow systems, and how do we integrate better centralized treatment. So the proposal we're putting in is actually training counselors at the sites and doing centralized supervision, and then having tobacco champions at the sites who really work with the workflow of identifying patients and communicating with oncologists. So we're doing a 3x2 design. We're gonna offer all sites training on kind of identification and workflows, but some sites are gonna get a tobacco champion who's kind of a point person to coordinate this and make that clinical connectivity. And then we'll see if some sites are gonna get a tobacco champion to really be doing the counseling on the sites, and we'll see what happens. So that goes in a couple weeks as a renewal, but we think that is a way to centralize things, but offer the training and the on-site personnel to really be able to bring this work into community cancer centers. So this is the Screen Assist trial. This is another NCI one that actually this paper is coming out in JAMA Internal Medicine in the first week of March. And this was based on preliminary work that we had been doing since the National Lung Cancer Screening Trial, and some ACS funded work on our single site looking at integrating tobacco treatment into the care of patients who are undergoing lung cancer screening. So again, really looking at an integration model, looking at a systems-based model. How do we bring in tobacco treatment to all processes of lung cancer screening? So for those of you who followed the National Lung Cancer Screening Trial, it found that that screening with low-dose community tomography helped identify cancers earlier on and could actually decrease lung cancer mortality. But another finding is that the cost effectiveness of this was much improved if you paired it with tobacco treatment. And so since then, there's been an explosion. NCI funded a whole series of trials called the SCALE collaboration led by Stephanie Land, and ours was one of them, to say, how do we do this? How do then we leverage those important trial findings? How do we use the teachable moment of lung cancer screening to help patients quit tobacco and really maximize the benefits of this early detection? So we use the integrated care model. So we basically integrated lung cancer screening into the delivery system. So when a patient got a lung cancer screening test ordered, we automatically got a note. So we got a daily notice of people and lists of people who were undergoing lung cancer screening. We used information systems to provide timely information. We knew if their appointments were getting changed. We knew what status they were at it. We included some decision support, did videos, and I'll talk about that, of primary care physicians, radiology clinicians, and tobacco coaches, embedded those in the systems as part of the patient outreach. We tried to link it to clinical care, but we had some privacy issues with those, so I can talk about that. But really wanted to, again, bring in the clinician counselor voice into recruitment and provided links to community services, knowing that there's a lot of social determinants of health that interfere with patients being able to quit smoking. And so we referred patients to community-based resources. So embedding in the IT systems, how did we do it? We actually had a live feed of the lung cancer screening schedule in the Epic radiology ordering system. We had a study access database that was linked to the hospital server database that actually, prior to COVID, when patients came in for the lung cancer screening, if they typed in the medical record number, we knew their study status, and later on we knew their screening results. And then we embedded videos with RedCap tailored to the study status and their screening results. So the RedCap videos were tailored. The big issue that we hit in that is the privacy issue, that we weren't allowed to pair the videos with regular clinical visits and messages. So we had to do them separately with encrypted emails, and we hit some barriers with that. I don't know how many of you try to have patients open encrypted emails. They just don't. So we're working on that. So our specific aim, so we proposed and we enrolled over 600 patients. We developed a centralized smoking cessation treatment at 11 sites throughout the healthcare system. That was our first aim, is really developing those chronic care model systems. Our second aim was to look at the effectiveness of the intervention on smoking cessation at 6 months, and we used a factorial design. So based on our previous work, we wanted to know if shorter or longer term counseling worked, shorter or longer NRT worked, and whether referrals to a community resource worked. And then our third aim was the implementation aim. You see the parallel of this to the previous study. We wanted to look at reach, adoption, implementation, and maintenance of the intervention itself. And so here's our intervention data sources. We had patient surveys at baseline 3 and 6 months. We had enrollment data that we did a deep dive into, and we're doing some reports on that. We had patient exit interviews. We did new counselor tracking data, so really in-depth tracking of the session attendances. We used screening data for the EHR, and we had cost data that was mainly documented by the counselors and the access database about the treatment utilization. So who is eligible for study? Again, in Spanish and English, patients do not have to be willing to quit smoking or willing to use the nicotine patch. So patients who were scheduled for lung cancer screening tests, they could not be there for a diagnostic or follow-up test. English or Spanish speaking, and they had to be able to give informed consent and could not be unable to consent due to medical, psychiatric, or cognitive reason. And the current smoker having smoked a cigarette in the past month, and they had to have telephone access. This study, we actually gave people a choice between doing phone or video, and the majority asked for phone. So this is the virtual counseling itself. Via phone or video, this is what the design looked like in terms of there were 8 arms. So those 3 components fell out into 8 arms. And we find help. It was interesting when we do studies over, I'm sure those of you who've done studies and integrated different digital supports have encountered this as it changes. So originally the system we were using, the video-based system, changed. The system that hosted the clinician videos changed, and the community cancer system changed. The community resources changed. So it used to be Aunt Bertha, and then it changed to Find Help. This is also stuff that I don't write about over the course of the trials. If you're doing trials over a few years, things are in flux, things change, particularly with the digital work, and it's so hard to keep up with it and look and deal with the implications of those changes. But Find Help was great, and it's available across the country. It's a database. You type in patient's zip code, you do a screener for their social needs, and then it shows them resources that are tailored to them. It's wonderful. It's a free service, but if you want to get reports on it, there's a cost. So these are the videos. Again, we did message developing. We talked to patients about benefits of quitting at lung cancer screening or losses from not participating. We integrated, and this is what we learned from an earlier ACS-funded smaller study, is that patients who are undergoing lung screening really needed time to make a decision about quitting smoking. And so we offered them the study and videos based on their study status at 3 time points. The first point was when they had a test ordered. We had a primary care physician and the tobacco treatment counselor talk about the importance of completing lung cancer screening and the benefits of cessation. So not only to promote smoking cessation, but to make sure they kept that appointment for lung cancer screening. The second point was at the time the start of the screening itself, and originally we had iPads at all the sites prior to COVID. That went by the wayside, but a radiologist talked about the importance of the study at that point. And then the third recruitment time point, a radiologist spoke, and their messages were tailored to their lung cancer screening result, and they got brief cessation advice. Oh, and the barriers, obstacles to use, as I'd mentioned, with our system, they wanted email encryption. We eventually got consent to text individuals, so we could text them the videos, but our system requires us to consent people to text them. So it helps with, the first video, which is intended to help recruit patients, couldn't be sent until after patients consented, but we used that, and we had to discontinue the iPads during COVID. So this is the recruitment. Here's the 3 recruitment time periods, and this is kind of the course of it. And I'll talk a little bit later about a study we published about when, prior to COVID, people enrolled. And we found this was very important, very helpful, that patients repeatedly had an opportunity to enroll in the study, and then those who enrolled in the study had videos with messages about quitting in the study. This is the article. It came out last year in JNCI Cancer Spectrum. We talked about clinical time points in lung cancer screening, and prior to COVID, we had enrolled 177 participants, and what we found was, and this was surprising to us, 31% enrolled at that point in lung cancer screening test was offered. 13% of them enrolled in RP2, which was at the time of the lung cancer screening, but over half of them enrolled after this lung cancer screening test result. That's particularly salient because about 90% plus get a negative cancer screen, so confirming that there's nothing suspicious there. What was interesting also is that what we did is just a calculation for the number of enrollees per recruitment days. And what we found from an efficiency perspective, though, is that that middle point, it was a briefer period. The RP2 is that period of lung cancer screening that we had a briefer period and more people to enroll within a shorter period. And in the third recruitment point, we had fewer patients enroll per day, but we had a higher yield of number of patients who enrolled. So it depends on what you're looking at. Because that RP3 period, when they get their test results, went on for so long, we recruited more patients, but it wasn't as an efficient way of recruiting as when we were recruiting at the time of the cancer screen. And these are important implementation questions. That's why I take time to kind of, as Jamie had said, as we're doing these studies, this wasn't a question we thought of or written into the grant, but as we're going, I think this is really interesting. Let's find out when people enroll and how we engage them and how much work it takes to engage them. Our results were slightly different post-COVID. We had more people actually enrolling in RP1, but I think there was a little bit of a bigger window at that time. I'm not going to get into all of the recruitment results. Mainly half of these patients were current smokers, but we ended up having over 80% recruitment rate at 3 and 6 months, and we ended up equally recruiting people. This just shows our randomization scheme worked, that we had 8 treatment arms, and we had about close to 80 people in each arm. Who enrolled in the study? We had half women, the mean age was about 64. A third only had a high school degree, so we felt like that we were happy that we were able to reach out to patients of varying educational levels in the study. We had, again, even though this is offered in English and Spanish, not as many Hispanic patients as we would like. 75% of them were addicted to smoking with a proxy of having a cigarette within 30 minutes of waking. Over 40% had more than 2 chronic health conditions. Only a quarter of them lived with a smoker. Their smoking per day was a little higher than we saw the cancer patients, about 16, and they had been smoking over 36 pack years. So pretty addicted individuals, pretty smokers who we believe would not have otherwise really engaged in tobacco treatment had it not been for this proactive outreach system embedded into the lung cancer screening process. And the baseline character. So for treatment utilization, what we found was for those who had been enrolled in the arms where they got 4 counseling sessions, mean of 3.2 were utilized. For 8 sessions, we had a mean of 6.6. The Find Help, the social needs screener, was not taken up by many, only about 25% of the patients who were enrolled into those treatment arms. But what we found is when we did enroll people, when people did agree to get screened for social needs, 92% of them had a need. So again, our next work and our subsequent grant, which hopefully you'll be a part of if we get funded, well, you will be a part of it if we hopefully get funded. We talk about kind of how to enhance that, but the top social needs that were identified were food insecurity, social activities, and loneliness were those really powerful voices we heard. Challenges with housing or paying for utilities, and some logistics like transportation and legal advice. We found that the uptake of NRT was very high for those who are enrolled to only 2 weeks of NRT. Almost 80% of them requested it. And for those who are enrolled to the 8 weeks of NRT, 25% took 4 weeks and 61% took 8 weeks. So it speaks to the importance of offering NRT. And we mail it to them. These are the primary and secondary outcomes by randomized group. So the yellow is the 7-month day abstinence comparing the lower intensity to higher intensity, that we had a significant difference in terms of that, and 24-hour quit rates. This is something that I really like to highlight, and we might be presenting on this a little bit at SRNT, is what we decided to look at based on some of our findings were not only what of the 8 groups they were randomized to, because they're a variable uptake, but what was the utilization. So one of the things we heard in the qualitative work was people were using other kinds of smoking cessation medication assistance besides the nicotine replacement therapy patch. So what we did was we looked and said, how many, not regardless of where you were randomized to, what did it look like if you engaged in 0 to 4 sessions versus 5 to 8, if you engaged in any medication use versus none, or if you were screened for social needs, whether you did it or not. And so what we found, if you look at the 7-day abstinence and significant reduction at 3 months, and also 24-hour quit rate, that what they utilized was very important potentially even more important than what arm they were randomized to. So what we found was more counseling sessions was associated with 7-day quit rate at 6 months and significant reduction. Any smoking cessation medication use was also associated with those, and 24-hour quit attempts, and engaging in social needs was associated with was associated with 24-hour quit attempts. Can you hear that? Hold on 1 second, I'm sorry. I turned down my phone, but I didn't turn off my phone. Okay. It's not a magic trick. I had it almost 5 years ago. I lost hearing in my left ear, and the phone was ringing into my hearing aids. That's never happened to me. Okay. So it's funny when I talk to people on the phone, because I can talk to people like that, and people look at me like I'm talking into I know someone's going to tell me, yeah, my grandmother has those, or my mom and my hearing aids. Yes, I have hearing aids now. Okay, so exit interviews. So what we did was we also did in-depth interviews with individuals after they completed a priority selection of interviews after they had completed the study. It really helped us understand, we want to understand the processes of the different components. So they perceived that cessation was definitely an ongoing process, and they thought the benefits were these emotional supports, particularly things like learning how to handle their stress and deal with triggers, and accountability and motivation. We heard about that a lot, and we actually have a postdoc who's writing this up right now, and this will be presented as well at it's going to be presented at SBM, but really talking about the importance of having someone there to continue coaching them with these skills and to continue motivating them, and that ongoing presence, particularly for people who are randomized to the 8 sessions. And regardless of whether patients were randomized to 4 counseling sessions or 8 counseling sessions, everyone said they wanted more. So the quote is, it helped me because of the strategies that I learned and having that support, that check-in. And then individuals desired continued support and accountability and interaction with others. I have tried to keep my commitment because there's a real person who's checking in on me, somebody who's interested that I quit. So actually the punchline is the next grant that we wrote, we're doing group-based work, and no one's done group-based work with these other individuals for lung cancer screening. And we're hoping that if we do a group-based process for this counseling and also for the social needs screening, that there'll be some support. We'll look at group versus individual, and we'll see how patients engage. And we also added some monthly booster sessions. So we'll be able to look at the impact of the group interaction, the continuity on hopefully their ability to quit. The social needs screener really came across the individuals who use the social needs screener identified loneliness and needs for social isolation. That's what we heard again and again. And we know that the Surgeon General's report last year showed that, we're really in a social isolation crisis in this country. And so we're hoping to be able to leverage that potentially in the next go around and look to see, can we introduce older smokers to individuals who are also experiencing the same thing? Will that help? Some felt the NRT helped, but others were ambivalent and desired other kinds of medication support. So we're going to offer that in our next work. And then when we asked people why they didn't undergo the social determinants of health screener, they just said bandwidth. They just were so overwhelmed. And again, potentially doing the screener group context and group support to utilize the services might help. Okay, so we have a couple of offshoots of these. These are briefly I'll touch upon. So Efren Flores is doing some work looking at sociodemographic predictors of enrollment, who enrolls and who doesn't enroll. This paper is coming out in nicotine replacement therapy. Jackie Adia is a physician and collaborator at UMass Boston, and she was looking at patients' perspectives who are undergoing lung cancer screening of using e-cigarettes and harm reduction in the context of lung cancer screening. It was a really interesting paper. And then we actually had less e-cigarette use than we did of cannabis use, and I wish, again, when trials go on, things change, but I wish we'd asked about types of cannabis use, and we did not. And that this is work that Rachel Rosen presented last year at SRNT that we're writing up, that she submitted, and we have a revise and resubmit, is to look at who among these older adults are using cannabis. Next steps, hopefully, is the collaboration that we're doing a group-based treatment, having some booster sessions, giving flexibility of medication, see what happens. And I want to thank everybody. These are the acknowledgements for this study. It's really a team-based approach. Both of these projects are a huge team-based approach. I've never presented them together, and it's really interesting presenting them together. the council had nicknamed them twin studies, and I see in doing this why. So thank you for the opportunity, and I'm happy to take questions. Except about my hands.
Thank you, Elyse. The qualitative feedback told you that folks wanted more,
Yeah.
but I would be apprehensive about advertising more or structuring more, but, because of the commitment. Because we often run into the thing that, I want to do 10 sessions,
right,
but after they get started, they want 10 sessions.
Right.
So how would you deal with that?
Well, that's very similar to what we dealt with in the first study where it's 11 sessions. If you say, it's almost, if you say 11 sessions, it's like they don't want to engage. So we say you're going to do weekly sessions and then every other month. And then if you want, we can check in with you monthly. So I think it's how you present it. We don't say 11, we say 11 sessions on the protocol and our languaging or our messaging. But we also say to people very strongly, like, they can engage in as little or as much as they want. And now that the smoke-free support study, the cancer-based one, we translated into clinical services at the cancer center, and patients don't take as many. They don't take as many sessions. Mm-hmm.
Just a quick question from that too. Do you think that maybe they wanted more sessions as a social connection? Like, do you think the group-based format might change that outcome?
Yeah, and the 8 sessions only lasted 3 months in the lung cancer screening, and we think that the 6 months, just like with cancer patients, like that monthly booster really helps, and that's what we hope to test is that connection, that accountability, but also someone there for them. Mm-hmm. I think is very important for these older individuals. Mm-hmm. So yeah, and I didn't get the fact that the lung cancer screening guidelines changed as we were doing the study, so then older individuals are eligible for lung cancer screening. So. Yeah.
I'm curious, particularly in the first study, if you looked at treatment type and if that might have affected people, either their agreement to participate or stay in or success rates.
Yeah, so I have 2 separate answers. I'm going to start with people who engaged in this, the people who are already enrolled in the study. So we bifurcated it by smoking or non-smoking related tumor, and we didn't see any differences in terms of success rates. Because again, we try to be very clear about the message that, despite how you got cancer, we want to work with you to help you quit smoking. The first question we were unable to answer, we were really disappointed. So the first question is about treatment type, I think, in people who engage in the study. And part of it is that, like, what's really interesting, again, is wearing the implementation name, is that in all of these therapeutic trials and all these NCI-affiliated cancer center trials, they don't document. It was so interesting, the kind of discussions in the graph, like this construct, like they don't document what we do is like all that enrollment stuff. And we got a lot of pushback saying it's too much work for the sites to document. So we don't have those characteristics that we wanted on patients. If you look actually at the consort for all those trials, it starts at number of patients. The N is the patients enrolled in the trial. Mm-hmm. And for us, I think as behavioral scientists, that's very foreign, but we just had too much pushback from the sites. They were not willing to do it. And in fairness to them, they don't have the systems to document that. Mm-hmm. So we don't know the answer to that question. We don't know the answers to a lot of those questions that we would have liked. Yeah. I would have loved to have found out about Hispanic patients in particular. Is it low? Are they being approached? Like, I don't know. And I'm unable to answer that. Right. Yeah. We did write in that we would do it in the study, but we weren't able to.
In regards to the patient barriers, specifically in survivors, in some work that we're doing developing a nutrition intervention for survivors, in the initial qualitative work, a quote that really stuck with me is someone who says, like, yeah, I know the benefits of eating healthier, I know the benefits of losing weight, but I just got diagnosed with cancer and you're telling me to stop doing something that brings me enjoyment.
Yeah.
I'm guessing, or I'm guessing that you would see that, or I'm asking, do you see that with smoking cessation, and what are some specific strategies that you use in addition to just presenting the benefits?
I mean, I think what you always want to say is, like, and this is why we do, and I didn't get into as much as the counseling, we do the pros and cons, is what we say to them, what do you like about, we don't just say, pros and cons is what do you like about smoking, what don't you like about smoking, what would be the benefits of quitting, what would be the benefits of staying smoking. And so when you engage in that, you know what they like about it. So we say to them, what do you like about it? And just having that conversation, I think, starts asking them that and acknowledging, not just saying don't smoke, but just like, tell me what you like. And then you would get that, like you would get all that food stuff. And somehow I think that helps you with building rapport when you're engaging them and saying, like, we get that you're like, there's benefits to these, what we call maladaptive behaviors. There's benefits to these behaviors, but really, this is one thing you can do to take control over yourself and your health at a time when you don't have control. So we don't want to take away your enjoyment. So let's find out ways you can enjoy it, but also really reinforce this. Let's help you figure out how to control, your course of your eating and find eating that you enjoy that's healthy. So I think that's it. But I think really engaging them in why they're doing those unhealthy eating behaviors, that like, I think those pros and cons and things are really important. And also just that asking them, what do they think would be the benefits of modifying their eating, and what would be what would happen if they didn't modify their eating? It helps them with some of that ambivalence around like what you're saying is they're saying, don't take something else away from me right now. And I have we're actually saying we're not taking it away. We're actually going to help you kind of steer it in a way that you're doing it in a way that's healthy and best for you, and we have the confidence you can do that.
So you mentioned for the first study that the 4 months post-diagnosis window was narrow as kind of a barrier. Is that from people doing the enrolling, the potential participants?
All the sites.
We try to do things with like very freshly diagnosed patients, and
Yeah.
we always get that it's very overwhelming, but then you mentioned that the benefit gets a little bit diluted if you don't get that timing, so knowing when to do it. You have any advice?
Yeah, I mean, it's right. Well, the other thing we did, I didn't actually get into this study, interestingly, as much, but in our study, and the reason I just remembered why, when we did it in our study, when we had the 2-site study, we were able to also look at patients. We did 3 visits. It was 4 months or 3 visits, whatever came later, because we also know that some of the patients aren't coming in that often. But when we were doing it, again, moving it to a clinical trial setting, we lost that ability to see how many visits they have. So some patients don't come in that often. That's another whole issue that I wanted to talk about. But how do we, we're just going to, again, when you're working with these sites, you want to, this is where like the pragmatic aspects kind of, I think, have to trump what we believe is like the effectiveness. Like if they need 6 months, they need longer to enroll 6 months, patient 6 months, then they can enroll a patient between 4 and 6 months, which is what we're proposing for our next study. Then we have to align with them and give them that opportunity. I think the yield is lower 4 to 6 months. I wish we could do those site-based visits, but we can't because I don't have those clinical records. But I think we just have to collaborate and say, okay, well, it's better to have a patient, give them that flexibility and allow them to enroll patients that they don't feel stressed out. Yeah. But I do think like a lot of people would say, well, we're never going to enroll them at the first visit. We're like, okay. But I do think that that helping patients in that initial period of distress helps decrease their distress with the same conversation about the enjoyment. This is something that shouldn't be stressful. This is something that's helping you have some semblance of control, and you just don't have any control right now. And that belongs in that distress period.
I never thought about doing it like within a number of visits.
We did, yeah. If you can see the number, again, this is something. There's so much variability in type of cancer diagnosis. It's hard to have this hard and fast rules, but it was 3 visits for our initial study. So if you can explore that, that's great. And then also then gives the people who are enrolling like some flexibility and helps collaborate with them, because it's hard for them and they don't want to miss. We had one patient who was enrolled like 4 months to 1 day, and we had to do the whole IRB deviation. It was something to do. It was really a mess. But we love them. We're going to go back to the patient. The CCPR lead said it was 1 day after.
I have a question. One of the things that was really striking on this smoke-free support study was how many folks were pre-contemplative and then didn't use counseling. I was curious if have you guys thought about with the next phase, like, does that group need something different? And I also,
people who are pre-contemplative?
Yeah.
Versus the sustained counseling.
Yeah.
Because remember, our counseling they are getting something different, because our counseling is like is stage-based. So they are getting something different. We spend a lot more time in those cognitive processes. And then engaging their families. It'd be really interesting to really, to doing a paper looking at like the overall smoking environment. Like, are they 2 different populations? Because we do handle them differently. It'd be interesting to see that. Yeah. But the counseling's different. So. In terms of the branching.
Well timed. Thank you very much.
Thank you all very much.
Thanks for coming.
Thank you.